This is Every Story Matters, Connecting Family Experience to System Change. I'm Jen Griffis, and this is Kim, and I will let her introduce herself first.
So hi everyone, thank you again, and I hope you guys are having a good Thursday. I'm Kim Hokanson. I am a parent of 4 children with SED who started with 1 child with SED, and due to the trauma of having a child with SED and not getting the proper services surrounded that child, now we have 4. So I am very familiar with the systems and the different tools and mechanisms within a system of care. I ended up meeting up with Jen, and she asked me to share my story with my oldest, and from there it's kind of taken off to where I was one of the 5 original parents in the state of Idaho to receive a letter of notation to work with them as they stand up a system of care in Idaho. And I'm still currently doing that, and the work has evolved because there is a settlement agreement. So because of the settlement agreement, the work is finally kind of shifting to where we're seeing policy change and permanent changes within the system.
I'm Jen Griffis. I was from Idaho, worked with the Idaho system, navigated it and supported it for about 10 years. I currently live in Anchorage, but am here to present on some of the work that we did in Idaho when I was there. My background is in education and library science, and I'm currently getting my doctorate degree in law and policy. And so part of what you will hear today is how to take that family experience aspect, which is something Kim and I have both lived through the system, and begin to shift some of that into actual policy change. We have no disclosures to no financial relationships and learning objectives. We're going to describe the collaboration between family leaders and system partners within Idaho's quality management process. You'll have the opportunity to identify the ways that family stories and experiences are collected and how they can impact change. And then really the majority of this time towards the end will be spent giving you a chance to think about how you might be able to create your own family experience project within your system. And we'll walk you through the steps for doing that. So we're going to do a little icebreaker activity. So if you can grab your phone and menti.com, you can either scan the QR code or you can go right there and type that in. What was it? So I see essential as the big one. That's a good one to see. Necessary, transformational, education, person-focused, complicated, hope, advocate, insightful, engaged, important, education, complex. Absolutely. Exhausted. We often hear that parents are so busy, how do they have time to engage? How do we do that? So there is a lot of complexity around that piece. More question. Why should we include family experience within systems of care? And you can just type a short little answer. They'll all pop up here. Why should it be included? Why are you here to learn about this? Knowledge, advocacy for the youth, to understand what needs to be changed, obtain a vision. Families are the experts. It's required. It is required, right? Systems of care, it's required. I'm actually going to talk about that a little bit. You get a better outcome. Absolutely. We can't change lives of our children without it. Family vision, see them as partners, not partners. It affects how they access the services, to understand. Who are we to say what will and will not work for families? They need to be in the forefront, understanding the reality of how systems impact policy and practice often don't match, right? And we'll talk about kind of a lot of what I'm seeing too is the sharing of knowledge and power. And we'll talk about that as we get into some of these examples.
Stories are important. In the beginning, before I met Jen, I did not realize how important my story was. It was not socially acceptable in my group, nor in my family, nor within my church to be having a discussion around the struggles we were having, the identified issues, behavioral issues, and challenges that my son was exhibiting. So it became very common and normal for me to not talk about it. So it was very, very shocking when Jen asked me if I was going to be willing to share my story. Stories have been around forever, and they have taught us so many different parts of our history. The first story was traced back as far back as 30,000 years ago on cave walls. Those gave us an interpretive drawing to continue to assist us today in understanding a piece of our history. Obviously, stories have continued to evolve. They eventually became myths and legends, printed stories, plays, and even songs. In the 1700s, stories began to take form of fairy tales, which originated out of France. So that was pretty interesting. All of these story methods continue to look different. We graduate today to now where we have social media platforms, influencers, and storytelling looks very different from now than it did then, but it still serves the same purpose. It provides us with a perspective. It allows us compassion and empathy and to put ourselves in someone else's situation, even if it is just for a couple of minutes.
The first time I heard about cans, I was in a meeting trying to establish Idaho's system of care, and Dr. Lyons had been invited, and I remember sitting there as the only parent in the room with a lot of system decision makers and attorneys, and I was amazed that someone had actually created a tool that centered on my story, because through our journey in the system that had never come up. That had never been part of the conversation that we had, the story behind what got us to that moment. Stories are powerful, and as parents, when your story is acknowledged and you have the opportunity to share it, it can be empowering for parents. So, Kim shared the history of stories and just how stories impact our life, but stories within TCOM carry some of those same characteristics. In TCOM, stories are transformational. Parents navigating mental health systems face challenges, not just the daily challenges of parenting a child with a mental health diagnosis, but navigating a system that's complex, that doesn't make sense. It's hard. But every parent that I have worked with has had a desire to change the system. When they experience those hard things, they want to figure out how to keep it from happening to the people that are coming behind them, even if it's just in a small way, even if it's just telling their story and their experience so that maybe the system realizes what's happening. So stories transform systems, but they also transform parents. Because being able to share your story and see it make an impact changes the way you interact with the system and the way you interact with professionals. Stories in TCOM are also collaborative. Creating safe spaces for families to share is beneficial to systems. I was able to listen to a Safe Systems workshop yesterday. It was mentioned again today. Safe Systems in child welfare is an exciting thing for me as a parent who adopted kids from child welfare to hear about. But when I hear about these judgment-free, blame-free spaces for child welfare workers, parents need the same thing. Parents need the same spaces to be able to share their stories that are judgment and blame-free. And TCOM can do that by creating this collaborative space that brings professionals, decision makers, policymakers, parents, youth together to be able to have those conversations. In TCOM, stories impact outcomes. Family stories improve the system. Stories can impact the system at both a policy level and at a practice level. Sometimes it's low-hanging fruit, right? Sometimes that story, it's like, oh, we can fix that little thing. Sometimes it requires something bigger, but they do impact the system, and they do have an outcomes aspect to them when systems are able to interact with them. And the last thing that they do is family stories impact management. So systems, child-serving systems should always be centered on the child and the family. That's it. They are serving kids, and they should be centered on the child and the family. However, most of our publicly funded child-serving systems are centered on the system. When we are doing our quality management, when we are doing our program evaluation, when we are doing our policy, when we are talking about this in the legislature, we are centered on the system. Making that shift to centering back on those that are being served is what helps us be able to manage publicly funded systems in a way that supports equity and efficiency. And those are two competing political goals, yet centering on children and families can kind of help address that tension and be able to manage the system in a way that moves systems forward and creates more positive outcomes and positive experiences for families. One of the other things I want to make sure that I say is we are talking today from the perspective of parents. Some of you in here may work with youth. A lot of what in my parent work, there's a lot of crossover. Idaho doesn't have a long history of good work with youth. It's definitely getting better, but the parent aspect is what started in Idaho first. In some systems, it's switched. Some systems actually do better work with youth than with parents. So I would just say if you are looking at how you can, cross this over into the youth side, I think there are a lot of parallels. However, as a parent of teenagers, Kim and I both can attest to the fact that it's not always clean. There are differences between working with parents and youth. So take what feels useful and leave the rest, and know that the intention is not to leave youth out of the picture, because they are absolutely a critical part of these systems. Okay, so we're going to move into sharing 3 examples of how family stories were used and are used. All of these are active projects within Idaho systems of care. All of these live, and this slide is really to kind of help you with the acronyms, right? All of these live within Idaho's Quality Management, Improvement, and Accountability Plan within Idaho's system of care, which is the Youth Empowerment Services System, or YES. So the QMIA and YES. Underneath the QMIA, there's QFAS, Quality Family Advisory Subcommittee, a family survey, and then the System Improvement Subcommittee, or QSIS. So that's just where we're going to be heading as we walk through the next 3 examples.
Okay, so QFAS was originally provided because we did have a lot of families that wanted to provide their stories within the system. And one of the most unfortunate situations that we've encountered is that when parents are coming forward to tell their story, it's typically because they're in this heightened emotional state. So we call that crisis. And so they're angry, right? They're angry, they're scared, they're feeling helpless, and it's difficult to put yourself in that vulnerable position when you're sitting in front of division administrators that are decision makers and people that have historically told you no. So a group, the Family Advisory Subcommittee, was created, and it is comprised of the Division of Behavioral Health, a Medicaid representative, a child welfare representative, State Department of Education representative, and juvenile justice representative. The key component of this group is that there are 2 permanent family members sitting on that group. Any family member is welcome to come to this group and share their story. All of the permanent members within this group signed a confidentiality agreement that information is not shared without the parents' permission. So those parents can come and go as they please to share their stories or to provide support for somebody else. What we do with those stories is, first of all, we allow them a platform to share their story however they would like. If it's angry, if it's tears and snot running, they get to do it however fits their comfort level. And when they do that, we pretty much dissect their story, and we start identifying those gaps and barriers that they encountered within our system, and then we put them into a tracking spreadsheet. So without having to target this family and identify this family on a system level, we can actually take their story and pull out those gaps and barriers. So one of the ways that we did that is we created a centralized complaints line. So the centralized complaint line can be used in multiple different ways. The key thing for families on the centralized complaint line is that it's anonymous. So they could call in, they could email in, they could go directly to the website and fill out a form that we have. They can attend QFAS, and they can call up a family advocacy organization that works closely with the families, which right now is Families and Youth of Idaho. So we do receive all of those complaints, and the whole group, including the 2 permanent members of the group, actually look at those complaints, and we track them, and then we prioritize them up to the QMIA Council, the Quality Management Improvement and Accountability Group, to submit formal recommendations on change. Oh, and we do also share the outcomes of that. So if we are identifying those trends that may be on a lower scale and be able to be fixed a lot quicker, then we can escalate those to their appropriate departments. And keep in mind, when I say centralized complaint system, it means that a parent can complain about anything. And it's not just a parent. Anybody can complain. A provider can complain. A child welfare worker can complain. The youth can complain. Anybody can complain and or provide feedback, and those complaints are actually directed back to the appropriate department. So if I called in and I said, I went in to try to get Medicaid for my child, and the person that was helping me was extremely rude, and my child's in crisis, and I still can't get access to Medicaid. So they're going to not only escalate that to Self-Reliance, which is the benefits program in Idaho, but they're also going to escalate that to Medicaid, because there has to be a different way for a family that's in the midst of crisis and their child clearly has needs that are not being met for them to access some sort of help. They're also going to be referred to the Family Advocacy Organization and potentially the Division of Behavioral Health, which can provide some assistance and services outside of Medicaid reimbursable services. So, yeah, that was it. Sorry.
Yeah, no. I think the thing that I want to highlight from what Kim said is that parents can submit concerns and complaints anonymously. That's not something the system tends to allow, right? They want to know, they want to track. Parents, when we were setting this up, we were like, they have to have that option. If they don't care about feedback, they don't care about knowing, getting it fixed, they just want to say something, they need to be able to do that. And to allow that really created, what it did was it addressed that power dynamic that we often see within systems. So pay attention for things like that as we talk about the family experience project. You're going to want to look for ways to pull in family experience and address that power dynamic that is just inherent within systems. Yeah.
Just out of curiosity.
Yeah.
Just out of curiosity, how would emails be confidential?
Yeah. So you're right, and there's a web form that they can use, so they can submit an electronic complaint without submitting an email. Does that make sense? But then they could also email, and of course that would be tracked, right? But because their email would be there. But there is that form that doesn't require an email in order to submit it.
And typically, the people that do submit the email are not wanting.
Exactly.
They're not wanting to be anonymous because they're looking for resolution, which I failed to mention. So there is a resolution piece to this as well. So typically, the Division of Behavioral Health, when they receive a complaint that the family member or the complainant wants a resolution, they will actually respond within 30 days with the next steps towards that resolution if resolution hasn't been met already. So we do actually have a process where the complainant is contacted, they're notified, we did receive your complaint, any additional information can be provided, and then it is escalated to the correct department, and from there the collaboration begins on how to address that specific issue, and then within that 30 days the complainant does receive that notification of resolution.
So the second example we want to share is the family survey. Conducting an annual family survey was one of the requirements in the settlement agreement. I actually, as I participated in that process, I remember seeing family survey on the list of requirements, and I was like, oh, great, that's going to tell us, basic information about families involved in the system. When I heard the results of the first survey, I was truly impressed. It went beyond just a traditional family survey. The family survey is conducted through a contract with Boise State University. Dr. Nate Williams oversees it, and it's a quantitative survey that is focused on parent experience within the system. But as any of you who have participated in quantitative research analysis know, it's not the survey that makes the difference. It's the analysis that's done with that data. And he does an amazing job with that analysis. After the first survey, he was able to take the questions and create a system of care adherence scale that we're able to use to determine, using the system of care principles, right, how providers are adhering to those based on parent perception. And if you Google System of Care Adherence Scale, you should find the academic article that was written based on that. So I see people looking it up. It was an amazing way to take what parents were saying and put it in a format that makes it hard for decision makers to ignore, because it's really taking that data and putting it in a form that's not typically seen. So the most recent survey, which the System of Care Adherence Scale was used for this one, and that showed that it highlighted that there were inequities in treatment for kids at the highest level of need. And from that, those kids were also less likely to benefit from any treatment that they did receive. Not only was it harder to receive treatment, and it was treatment that appeared where the quality was less, it did not adhere to those principles, they were less likely to benefit from the treatment. The survey data confirmed the family stories. I remember when Nate realized this came out of the survey, he was like, oh my goodness, that's what families had been saying in the stories that we were gathering from what Kim just shared, right? So there was confirmation there between the two, and it really showed that there's a need for more community-based services that target youth with higher levels of need. There was also some inpatient hospitalization data that came out of that kind of showed that those services were not really effective. They were more likely to experience repeat hospitalizations. Admittedly, this data was during COVID, so we had to take that into account, that there may have been some questions there, so we're watching that to see what happens. But based on the trajectory of the system, what we know about the system, it really confirmed what parents and providers had been saying. And to be able to see that come out in something like an academic article, that's exciting for parents. Like, even in the midst of the hard story, their kid not getting treatment, to know, okay, wait, like, this isn't just me, I didn't do a bad job navigating the system, this is something that needs to be changed. It also provides the leverage that agencies needed to be able to push legislatures to make some changes, be able to kind of work on some things that needed to happen in the system. This survey is also an example of co-researching. So co-researching is co-creating research projects, and I use the term research very broadly, right? You don't have to just think of academic social science research, but it's co-creating these projects with parents, involving them in all or part of the research process. It is a very different model from just a typical survey or a focus group. It moves us away from that we're going to take the information from parents and use it for what we need to use it for, and maybe we'll let them know about it, maybe we'll forget, and actually embeds them in the process. So within Idaho's survey, parents were included in the development of the questions, in the wording of the questions, multiple edits back and forth, trying to find a place that felt like it would provide the information that was needed, but that was respectful of where parents were. They were consulted on the meaning of the data after it was analyzed, and then they were able to participate in sharing the results. So parents were embedded in the process the entire time. It's not a perfect model. There are still spots where parents are not included, but a lot of that lack of inclusion is because it's a contracting process with the state, right? There are just some limitations, but it's an example of moving away from that mentality of parents just giving their knowledge to the system and then just having to see what happens with it. Instead, they're actually able to kind of embed themselves in that process and experience it and provide their feedback in the moment.
Okay, so the third group that came, well, the third thing that came out of the QMIA Council was a QSIS. So this was partially started because of the information that was brought into the Family Advisory Subcommittee. One of the largest things that we were identifying as an issue were families being discharged out of hospitals. So it didn't matter the hospital setting. It was acute, it was the emergency department, it was psychiatric residential treatment facilities, and they were being discharged against the family's wishes. They were being because they didn't meet the eligibility criteria to stay there any longer, the kiddos. And they were also being discharged with inadequate discharge plans. And when I say inadequate, the most common things that we find in those discharge plans is call the police, which is not the answer, especially for kiddos with serious emotional disturbances. And so we decided we needed to take a larger look of what this looks like, because there's obviously different types of discharge depending on the level of care. So we started a discharge planning process where we created a document and we actually spelt out what discharge currently had in both CFRs and the IDAPA codes for every level of care for families. And so in all of those areas, they handed that paperwork to family members to see how much of that information families truly understood. And I can tell you, for someone that's been doing this for as long as I have, most of that could have been written in any other language, and I would have not understood it. So there was no way for me to understand what my rights and my responsibilities were as a parent of a child that's discharging out of any level of hospital. So we started, first of all, making that language a lot more family friendly. So after the family friendly language was integrated into that document, we started changing the way that the process occurred. So one of the examples would be if my child was discharging from an acute hospitalization after an attempt of suicide, then certain things needed to occur. First of all, a case manager tied to the hospital needs to make contact with that family. So now this is going to be one of the requirements. So when that case manager is contacted with the family, which may be on day one of my child being placed into the hospital, they're going to explain to the family, we're not discharging you, but we are going to work towards something that is inevitable, which is discharge. So what do we need to do to get to that point for you and your child? And so when those goals and objectives are met, then we can start creating the discharge plan. And so first of all, we actually changed the language. It's not discharge anymore. So now we're calling it transition, because I can tell you from a parent's perspective, I do not like the word discharge, because I have never once had a situation where they said discharge and I was excited. So we did change it to transition. So the transition plan would occur. So now in that transition plan, originally the recommendations would be to reach out to your natural supports, or to follow up with your mental health provider, or to call the police. So first of all, I didn't have a natural support system, because I spoke earlier about the fact that it was kind of this thing that was not discussed within my group and with my circle and my family. So I didn't have natural support. So that's now out of the question. I think we're all experiencing the workforce shortage across the nation, and there's wait lists. Definitely in Idaho, there's wait lists. And so if I don't have access to a mental health provider, who am I following up with, right? So that is an inadequate recommendation on a discharge plan. And the police, again, is obviously very not appropriate for a child with serious emotional disturbance. So what we did is we fine-tuned each one of those pieces. So in my situation, if I didn't have a provider or natural supports, then we would start creating that. So then we would start the CFT process, right? So who do you have? What does your son play sports? So my son's football coach would have been brought in, and my son's principal would have been brought in, because he is going to have to go back to school, and his counselor would have been brought in, his DD worker would have been brought in, his CBRS would have been brought in, his counselor would have been brought in. And we would create that team, and that is now going to fulfill that area of natural supports. And not only do we create that list of names and phone numbers, but the discharge can't occur until there is a locked-in follow-up date. So their appointments locked in with the provider agency, and also is meets the needs of the family. So the second piece with the provider, if I don't have a provider agency because there are wait lists, then what is the next step? And in Idaho, for my family, would have been to contact the Division of Behavioral Health Children's Mental Health Agency and start the wraparound process. So then I could start utilizing the most that I could get without sending my child home into a cold setting, which is intensive 24-hour, 7-day-a-week care to nothing. And so that was also spelt out. That contact needs to be made, the very first meeting time, date, phone numbers, all of that has to be established before the discharge plan, the transition occurs as well. And I have been very strongly encouraging them not to call the police as one of the options. That is obviously a last resort, because unfortunately with my child, he did exhibit a lot of violent and aggressive behaviors. So right above that, we did decide to call the mobile crisis unit before utilizing the police. And so that was another nice shift in that normal process for them.
Okay, so now it's your turn. You have an opportunity to think about creating a family experience project. Okay, so when you are creating a project, this is really basic project management, like life skills type things, but we're just gonna walk through these steps. And I'm gonna highlight some of the things that we talked about as Kim and I were sharing the different projects in Idaho. The first thing you're gonna do is you're gonna select a topic. Consider something that is low-hanging fruit, so an easy aspect of your system, right, where you could embed parent voice, you could pull parents in, or consider something that parents have been frustrated with, or that you've heard a lot of concern or complaints about, because those are topics where parents are probably going to want to actively participate, right? So you can take it in different directions, but think about a topic. Your selection of a topic is going to really vary based on your system and kind of where your system is with parent involvement and what resources you have. That's your first step. Your second step is to prioritize parent experience. So as you're thinking about this topic, how can your work on this elevate parent voice in a way that it hasn't been elevated before? How can you approach the project that prioritizes parents as the experts, right? We saw that up on the board during our icebreaker, that prioritizes them as experts. So it's that sharing of knowledge. Their knowledge as a parent is just as valuable, if not more valuable, than that of the professionals, right? Or how can you prioritize shared decision making? That is the sharing of power, and our systems struggle with that. Someone said that we need parent voice because it's required, right? It is. System of care requires it. Yet it tends to be token parent voice in most systems. It is very rare to find a mental health system that is actually able to consistently, authentically include parent voice and expertise within their projects. So the way to move away from that tokenism is by finding ways to share knowledge and share power. That's challenging for a lot of systems because that's not the way they're designed. But this is the way to start taking those steps in that direction. So the next thing you're going to think about are just the project details. Who needs to be involved, right? What are the boundaries of the project? Who needs to be involved? Who are the system champions that could help move this forward? Because you have to have a system champion. Our system would not be including parent voice like this if we did not have strong parent consultants, someone in charge of our quality department who has background and an understanding, and our researcher who is totally bought in to the importance of parents, right? We have got some strong champions that keep pushing this forward. So who are those champions? Who's that person? It can be anyone. It can be someone in a nonprofit agency, an advocacy agency. It could be someone within a state agency that has some lived experience, and so they're a little bit more aware of the need for this. It could be that you've got a strong parent or youth voice already, but identify that person. What are the organizational limitations to consider? Organizational limitations exist. We have hard boundaries, right? Hard boundaries are a reality in this work. So just acknowledge them. What are the things that you're not going to be able to change that may impact your ability to include parent experience? And then in good CANS fashion, what are the needs and strengths of your system related to this project? just another good thing to think about. And then the last step is determine the outcome. Before you even start, what's the outcome that you want? Are you wanting a policy change? Are you wanting to just get more information? Is it foundation work that you're looking at? Are you just wanting to start to invite parents into the conversation? What's that outcome that you're looking for? Because that will tell you the scope of your project. This may change, right, as you work through the project, but you want to have, like right now, what is that outcome? So we're gonna give you a few minutes to kind of think through this yourself, jot down some notes, and then I'll invite you to maybe turn around and group up, maybe groups of 5 or 6, and if people want to share, and then maybe invite at the end a couple of people to share if you had thoughts and ideas, and then we'll have time for questions too at the end. So I'll give you about 4 minutes or so to kind of jot some notes down.
One question we had, what do you see as the biggest success in the changes Idaho's made and what you see as the biggest remaining challenge?
Wow, that I feel like that's a loaded question. Okay, so I'll start. I think that the biggest success would have to be that the parents and the youth being included is no longer a second thought, right? It is almost an automatic thing that tends to be occurring now, especially as we are evolving in our implementation phase here in Idaho. And it's a comfort. It's a comfort to know that enough of our stories have impacted the system enough that they're seeing the necessity and the importance and the value as they create a whole new system that we all hope will be more collaborative and beneficial for the vulnerable families in Idaho. And I think that the survey that Jen had spoken about during the presentation, I really affected that shift in culture here, because for that data to really represent what we've been saying all along was really key for us. And I don't know that I should be talking about any type of failures or anything like that.
So I agree, Kim. I think that the fact that it's just is becoming second nature to include those stories is a huge win. I think also the fact, so the biggest win for me personally is that there's not just one parent. When I started this work, I was the only parent, and even just in leaving Idaho and leaving this work directly a year ago, knowing that there were multiple parents and that the system had embraced the idea of multiple parents, and that even in a meeting that it wasn't a problem to have more than one parent. In fact, that was expected. Just starting to see that was a huge win. I think that probably the biggest challenge for any system, not just Idaho, is that typically when it comes to parent and youth engagement at the system level, it happens because there are champions. There are people that are helping to move that work forward, whether it's people in the system or people or providers of services or parents themselves, nonprofit agencies. There is someone that is helping to move that forward. And if you lose that person or that organization or something happens, you risk that engagement not being what it is. And I think that's the biggest challenge in any system that's trying to do this work, is really creating a culture and kind of shifting that culture so that you can, those champions can shift and move and be in different positions in different places, and that culture still, and that expectation still stays the same.
Can you speak a little bit more about that? I'm curious to hear, from those of us that enter these relationships kind of from the professional side, right? When you say that you find that you sort of need and that the relationships work best when you have those champions, what does that look like? What is being championed, and sort of how does that actually look from your perspective as a parent?
Yeah, so I think the first thing is it really tags on to what Kim said, right? It's the fact that people don't. It's not a second thought to include parents. It's kind of the first thing, right? We need to make sure we have a parent on this group that's going to be exploring this challenge that the system's facing. I think that's how it looks from the parent perspective. We're not the ones as parents that are having to remind the system to include parents in the conversation. I think the same thing could be said from the youth perspective, right? It's not the youth, it's not the parents, it's not the advocacy organization that's having to remind them of that. It's the system itself that has kind of created that culture, and to get to that point creates you have to have those people that are willing to relentlessly keep saying that. Those are the champions, right? It's the people that will just keep putting that out there, and reminding the system of that and that need until that culture starts to shift and it becomes second nature.
Yeah, well said, Jen. I think that in the beginning, especially when Jen had started and she was a solo parent without that peer support, I'm sure it was very daunting, right? You have a parent experiencing her own struggles within a system, and she is sharing her own experiences with those challenges in front of a group of administrators and decision makers, right? That would be overwhelming for anybody. And she obviously handled that with grace because the system did shift. So at that time, I mean, I think what some of the key champions would have been the attorneys, right? We are in this unique position where we have the attorneys heavily involved because there is a settlement agreement. And now that has greatly shifted to where we actually have the divisions themselves asking for parents. When they're seeing enough of the need and the importance and value in these stories, and being able to see the services within the system that they're standing up from a different angle versus white paper, then they're able to look at the broader picture, see the implications with each of those services. And it's because of the stories and the experiences with both the parents and the youth navigating that system. And so now the champions have shifted to where the division administrators and everyone else, they're becoming partners, right? It's a partnership now. They are just as much our champions as the attorneys began.
And I am not seeing any other questions right now in the stream. We did have a little audio hiccup sort of at our initial part of the conversation. So you both spoke eloquently and only to me, it turns out. But if you want to, just kind of wrap this up by reiterating any of those opening statements that you made, just about sort of, what were some of your takeaways from your talk or anything that you wished you had shared and didn't have a chance to, and then we can wrap up from there.
Yeah, so I had just shared that connecting our presentation to the youth-centered care roundtable that was presented yesterday, that they talked about the levels of engagement, and that our presentation and kind of some of the ideas in that are really focused on helping systems get to that highest level of engagement with parents and youth and families, kind of moving away from that tokenism, from being kind of the lone seat at the table. And just the idea that it's not easy, it's messy, it's uncomfortable, and that if it feels comfortable, you're probably not at that highest level. Because in order to really address those power dynamics that are just so inherent in our system, requires a certain level of discomfort on the part, especially on the part of systems and system administrators.
Yeah, and I was just really echoing what Jen had mentioned, because it is, I can tell you that when I had first started in this work, I leaned heavily on Jen. She was and is my mentor still to this day, and I continue to really reach out to her and kind of bounce things off of her, because even at the highest level, we still need that support. I hope that people are taking that away as well. It is very intimidating, especially as we're onboarding new parents and they reach out to me. I think the first thing out of their mouths are, "This is really scary. That was really scary. Did I do okay?" And so hopefully people are taking away from that as well, that even at the highest level, we all are still very nervous and anxious about what our value looks like at the table.